introduce our wonderful speakers tonight. So I'm going to start with the one that has better hair. So, Rommie Duckworth. Thank
Oh,
you so much again, Mr. Duckworth, for being on with us tonight. So, Rommie is an emergency responder, educator, and author of over 30 years of experience in fire rescue and EMS. He is a career fire captain and EMS coordinator and has written hundreds of articles on rescue and pre hospital trauma care. Oops, sorry, my screen moved. He's also contributed to chapters in more than a dozen tech books, including PHTLS. He currently serves as the NAEMT liaison to the American College of Surgeons Committee on Trauma, EMS work group, represents NAEMT on the National Guidelines, project for traumatic out of hospital cardiac arrest management and is the member of National EMS Quality Alliance Post Crash Care Technical Expert Panel. As a presenter for MTAP, Rami supports its mission in improving patient outcomes through high quality trauma education. So thank you again, Rami, for coming on and speaking with us tonight. And then, of course, this gentleman probably needs no introduction. My husband, Joel, is speaking with us. And I had never read his bio until tonight, actually, funny enough. So, Joel is a paramedic serving as the EMS education coordinator for the State Department of Public Health. He has 30 years of experience in community based commercial and critical care EMS education. While serving as a regulator, Joel continues to practice as a paramedic and clinical preceptor in the state of New York. His newest partner also happens to be his 18-year-old daughter, Abby. So, thank you both for coming on and spending some time with us this evening, and I will turn it over to you guys.
well, I don't get to say this on presentations usually, but thank you, dear. It's good to have family in here tonight, and I'm really excited to see that we have over 100 people participating with us tonight from across the country. And a quick shout out to my neighbors here in Connecticut and New York. So thank you for supporting us. My partner in crime tonight is Rommie Duckworth, and he comes without saying one of the best speakers on the national EMS circuit. In fact, most of you will recognize that I have my Duckworth duck here with me because that's what Rommie hands out at the conferences. And if you haven't seen him in person, you should know that that is an official Duckworth duck. So, Rommie, I don't think you were able to make it, but I spoke in November. And a few of the people who are on right now saw that in November. We talked about when resuscitation was a futile effort in trauma cases. In fact, let me put up on the screen real quick what we shared. And you take a quick look. We talked about all the times when resuscitation was not worth it. And somebody give me a thumbs up if you see that screen right now. We Thank you. We talked about the things that do work. We talked about bleeding control, hemostatics, tourniquets, pelvic binding, some fluid resuscitation, TXA, decompression. But we didn't go into them in depth and talk about the science that was behind them. So I really wanted to take some time to go over that today. And maybe you can share a little further information with us. I'm going to take that off the screen because we've seen enough of what I did. So, Rami, tell us tonight, why are we talking about traumatic cardiac arrest? Why is it an issue? I mean, we've been doing CPR, we've been doing ACLS, we treat people, we intubate them, we give them epinephrine, we shock them, and we go to the hospital. What's different when it comes to trauma?
Well, one of the things that we've been doing is reevaluating exactly how futile trauma is. Like you said, there are times, and it's unfortunate that it's still the majority of times when we're talking traumatic cardiac arrest, that we're not going to have a positive outcome. In other words, somebody's not going to go home from the hospital from a traumatic cardiac arrest the majority of times. But what we used to think of as like 0 to 1% or 1 to 2% over time, like there's a 99% chance this person wasn't going to come home from the hospital. So unless you really thought you had a chance, if it was traumatic cardiac arrest, we weren't working it, that more recent data and a better analysis of the data is now showing 4 to almost 10% of patients who get those kinds of interventions, LSIs or life-saving interventions that you just showed on the screen, they will have a chance of not just getting pulses back, but going home from the hospital. Now, again, 90% weighted towards not going home from the hospital. Still not good, but man, to go from 0% or maybe 1% to 10%, 10%, I'll take those odds, because all of those things that you showed, they're all within our capabilities as EMTs and paramedics. It's really just a matter of making sure that we're moving efficiently and getting straight to prioritizing the things that will make the most difference for these patients, which is in many cases going to be different than medical advanced cardiac life support or regular ACLS.
So a couple months ago, I cited Shimatsu, Rosemary, Stratton, a whole bunch of the big studies that really showed that 1 or 2%. What changed since then? What are we doing differently? Are we just counting differently? Are we giving something better? What does the recent statement from ACS say about resuscitation and traumatic cardiac arrest?
Well, it winds up talking about, of course, I should start with there's in the recent joint statement from American College of Emergency Physicians, National Association of EMS Physicians, and ACS-COT, American College of Surgeons Committee on Trauma. They issued a joint statement. Now, that's separate from the guidelines that we're working on that'll be coming out probably next year, because that's a larger project that involves some of the same people who put out this statement that looked at all of the data that you're talking about. And we're looking to put together guidelines, and that's going to be with the American Heart Association, American Academy of Pediatrics, as well as NAMT and all the aforementioned, multiple letter groups. But one of the biggest things for any research and any numbers when you're talking about cardiac arrest is it's almost impossible to separate out different aspects of these bundles of care. Maybe that's a bit of an overstatement. It's very, very difficult because, of course, we're always doing a bunch of different things. There's so many variables in what we do, and that's even more so in traumatic cardiac arrest than it is in medical cardiac arrest. So where some of these bigger numbers are coming from is a more focused extraction of the data, where they're saying, okay, but when we're looking at where, as you say, we're not prioritizing CPR and epinephrine and defibrillation first, like we do in medical. What if we take a look at the things that happen the most often in traumatic cardiac arrest that are the most catastrophic? Massive hemorrhage, pneumothorax, even further down the list, pericardial tamponade, but, those kinds of things, massive hypovolemia and bleeding out. We take a look at those things and do these numbers change at all when we start prioritizing? Like, look, before we jump right in there and do CPR, which is so important to have that rock star CPR in medical cardiac arrest, maybe in traumatic cardiac arrest, if most of the time the reason the person is in cardiac arrest isn't necessarily that their heart has stopped beating, maybe it's moving, but it's got nothing to pump. So why are we doing CPR over the priority of hemorrhage control and getting some kind of fluid in there for the heart to be able to pump around? So we want to change up our priorities. And what they found is that when they started doing that the numbers started going up and up and up. And again, it's ranges because, I don't want to say like, oh, well, in everybody's community that there could be a 10% chance. It may not be that high depending on your individual resources, but really, forgive the longer answer to that question, but it's complex because of these bundles of care where so many things are happening and so many different approaches to the research to sort of untangle this knotted ball of all of the variables involved in traumatic cardiac arrest. So we reprioritize, and when we reprioritizing, they're seeing those numbers go up. That's, I think, the big take home here.
All right, it's fascinating, but you've been in the job for a couple of years. I've been in a couple of years. Looking here, the list of people. Mike Robinson's up here. He actually got his paramedic card. It was engraved in stone when they issued it. So I remember the traumatic cardiac arrest, the motorcycle down, 2 large bore IVs, 2 liters of ringers, 2 liters of saline, mass trousers, a little bit of CPR, a bunch of epi, some bicarb, right? It all and we brought a well watered down dead person to a trauma center 30 minutes away. then a couple weeks ago, I do a cardiac arrest regular in the house, put the defib pads on, confirm it's asystole, work at asystolic code. In that case, we had to transport, still had the same outcome. What's different now? What's different in traumatic arrest versus my ACLS card in my wallet?
Well, we've been looking at a lot of the different aspects of cardiac arrest management because you can still look at epinephrine. In medical, we tend to look at epinephrine from its effects on being able to, let's just call it restart the heart. Obviously, it's more complex than that, but to get the heart doing something where we can defibrillate it. But we also know that epi is a vasopressor. So it raises questions. And I'm just using this as one example where, like, okay, so maybe in traumatic arrest, we don't need epi to restart the heart, right, and get it quivering more. But could it be useful as a vasopressor? So we've looked at it in a lot of different situations. Again, there are so many different variables. It's really tough to pull this apart. Early epi or later epi, or well, they used epi, but maybe it didn't do everything that we wanted because they didn't have enough fluid on board, and different variables like that. So it becomes more and more challenging. And I think really some of the first steps, and this is arguable, but from my keeping up with the research of like you say, where did we go from what you and I were taught years ago to what more recent medics were taught to, looking towards the future? A big change was when the European Resuscitation Council, you can think of them sort of like the AHA for Europe, as well as the Australasian and New Zealand resuscitation committees. So basically, the big resuscitation committees outside of North America started saying, hey, traumatic cardiac arrest is just different. So again, let's take a look at some of these reprioritizations. And when they started to introduce these ideas, it was a big shock for a lot of us who are saying, "What are you telling me that when I get to a traumatic cardiac arrest, I don't do CPR?" And this is the challenge that we're working on in making these guidelines. We're not saying like don't do CPR as in if you see trauma, there's no CPR at all at any point. It's more about how do we convey the priorities, making sure that, first of all, that the tank stops leaking, right? We're doing any hemorrhage control we can. Second of all, we're putting something in the tank. And again, even that can be like, oh my God, but wasn't that old school? And didn't we stop doing that? Putting fluid in the tank, and we're putting in saline or ringers, and that's, just making pink Kool-Aid, and we're getting rid of the clotting factors. And again, there's as they're looking at it, they're trying to refine this balance. They're trying to look at the parameters on this is how much is the fluid diluting the blood clotting factors and oxygen carrying capacity versus, well, if there's not fluid in the body for the heart to pump or for us to pump with CPR, then nothing's going to survive anyway. So where exactly is that sweet spot? And that's when we've been moving towards. And again, I don't want to give kind of a phony baloney answer, but we're not there yet. We know topics that we should be looking at. But again, it's instead of those mask trousers, we're looking at yes, dealing with shock, but it's a little bit further down the road. One of the best ways that I've seen it and the way that I recommend it and teach it is we borrow the mnemonic from tactical medicine. March, massive hemorrhage. We got to deal with that first, top priority. A and R are airway and respirations, and they virtually go together. Yeah, we got to manage the airway and we got to ventilate, but they're going together. Circulation, which is shock, which the mass pants used to deal with. But now we're looking at, balancing that fluid and keeping a real close eye on it. And head injuries and hypothermia, probably overall looking at that hypothermia and keeping somebody warm. Like when you and I were starting all of this, keeping somebody warm as a trauma patient is a critical factor. Wasn't anywhere on the radar unless you took a very different class than I did. I didn't hear about that for years and years. And now we realize that heat loss is a major factor. And man, we should have seen this coming because we see them take care of that in the ER when we come in with our trauma patients. So they put the bear huggers on and they get them warm right away, right? So again, forgive me, a big question, excuse me, a big answer for a big question, but we're really still trying to sort some of this out.
Well, I sound guilty. We were taught trauma naked, right? You put the person in their skivvies onto the backboard, which was still wet with snow, and then we got in the truck. We were all sweating, so we opened the windows a little bit, and we took a cold person in with diluted blood volume. So we thought we were doing a good job, but like I've always heard, 50% of medicine is wrong. In 10 years, we'll figure out which 50%. So we kind of have an idea how ACLS is going to go. We see that it's progressing as time goes on. Epi is a priority this time. It's maybe a little less of a priority another time. And Craig just asked, what's the C in March? It's circulation. It's ensuring that they have adequate perfusion and something to circulate, whether it be blood or a little bit of pasta water to expand their blood. So we're going to give them a little bit of saline or some blood product if it's available. So, Rommie, let me see what we do with an actual scenario. If I dispatch you out to a scene, you get to a car accident, or I just saw something that was on Facebook today. It's a cardiac arrest on the roof of an industrial building. Obviously, it had a traumatic cause. Something happened there. What's your top priorities? What's the first thing you do? We got 60 to 120 seconds to manage the patient and decide: is this going to be a traumatic arrest or a by the book medical arrest?
Well, first of all, and I hate to start with the scene safety, but we got to make sure that we're approaching it safely. And that's not just from a matter of, we're putting gloves on before we walk in and we're checking for people with weapons. But we're also talking about in so many traumatic cardiac arrest scenarios where we may need to do an emergent move to get the person to a safe place for us to be able to start taking care of this patient. So when I say safety, that's what we're talking about for all of it. The second thing is that M in March, right? Massive hemorrhage. If I say bleeding to you, it could be a scrape, it could be some road rash, but massive bleeding, blood actively coming out of this patient in a life-threatening way. We're going to start addressing that immediately with direct pressure as usually the fastest way that we can do it. And I know I always wind up getting discussions with people who say, but if it's an extremity trauma and it's external hemorrhage, why aren't we going for the tourniquet first? Okay, if you are ready and prepared, and you're one of those people who walks around with a tourniquet in one hand, and man, you've trained for months or years to be able to slap that sucker on and get that down and get it cranked down in place that rapidly, good, go for it, right? But the first thing that for most people will be able to get it stopped is just that direct pressure right on that spot. And from there, we can start with detect the bleeding, find out exactly where it is. And maybe we do need to do some exposure like you were talking about, Joel, but certainly also keeping the heat in mind. So we're not necessarily going to strip and flip. Direct pressure, detect direct pressure, and then devices generally. Again, if you have an exception to make for that rule, okay. So we're going to work on stopping our external bleeding, major bleeding, and then we're going to make sure that we've got that airway controlled and that we're getting ventilation in with chest rise. And we're going to take a look at evidence once we're ventilating this patient of a pneumothorax. Again, no one's recommending anymore the bilateral chest decompressions. I mean, even that wasn't even that long ago that it was just, look, if it's traumatic cardiac arrest and we think something might have touched their chest at some point, depending on the system you work in, hey, we want to dart both sides of the chest. And now they're saying it's not even that it's going to necessarily hurt the patient so much. It's just, it's going to distract you. And it may take you a little while to actually make that work. So if you have a reason to do it, go for it. Otherwise, let's move on. And we can begin that. We could take a look at do we need to put fluid into the patient before we begin CPR? Or do we believe we've got some fluid in the patient? We could start our compression. So at this point, we're starting to think about compressions. It adds it a little bit more, but because we've mentioned it and we mentioned fluids and blood products, that right now a big thing that's up for debate is sort of system-wide. When we know that blood products, if someone lost blood, that the best fluid to give them back is going to be blood products for an individual. But it's challenging right now for a lot of systems to make that decision, even if they have the capability of administering blood products, to say, okay, if most of the people in our system in traumatic cardiac arrest still aren't going to survive, are we going, and of those patients in traumatic cardiac arrest, they're not going to need a little blood. They're probably going to need a ton of blood. Do we want to take all of the blood resources on our system and devote them and just pour them into people who are not necessarily likely to survive that cardiac arrest? So again, looking at some of the thorny subjects, but it comes back to that scene safety, making sure not only that we're going to be safe, but that we can operate, maybe pull this patient out if we need to a safe area to start work. Massive hemorrhage, we're going to stop it. Any external bleeding. Detect, direct pressure, devices. Your mileage may vary on what you have available and what you're going to do. And from there, our airway, our respirations, and then we'll work on the circulation. If we've got something to circulate, sure, let's start CPR. If not, let's make sure we got something inside that person to start circulating. And at that point, you know, a little bit further down from your initial minute or so, then we're thinking about how we're going to manage this person's ventilations if they got a head injury. And overall, what do we need to do to make sure that this person is at least not losing any more heat?
You know, it's going to take me a little bit of time to get over that hump because, you know, I've carried my AHA instructor card in my wallet and 20, 30 years now almost. And I go around and I can rattle off CAB for the community, right? We do circulation first. If anybody doesn't have a pulse, somebody's pounding on that chest immediately. And then I bring over my favorite firefighter. You know him too. His name's Lucas. And he does absolutely perfect CPR for. So we're saying maybe we're going to adjust that a little bit in the near future. And maybe when we have an exsanguinating patient that there's going to be no blood circulation, we might do something in a little bit to fix it. What do you think?
Uh, Absolutely. And you hit on the key point here because people will often say, well, okay, why not? And that's one of the things that was really eye-opening to me to get a chance to work on this guidelines project. Is I'm the like you, Joel, I'm the implementation guy. I'm like, okay, how do we take the research? Let's ask good questions. Let's look at whatever data we have, and hopefully good data. But then let's make it have meaning for the EMTs and the paramedics that are going to be out on the highways at 3 o'clock in the morning, right, on a dark and stormy night at this car wreck with somebody bleeding out on the side of the road. Make sure that whatever we're saying with these guidelines, it's not just data, but it's something that can really make a difference for them. And that's where it comes back to, like you say, doing the CPR, making sure that we're pumping that circulation. And we say, well, can it do any harm? Right? What's the harm in doing the CPR? Okay, so I'll start CPR and then you try and put fluid in. Well, the flip side of that is if you're doing CPR on a patient who is bleeding out before we've managed to control all that bleeding, or even if we're fighting to control the bleeding, that CPR may take away resources that we could use to get fluid in, get the patient moving to the surgical suite, some of our other priorities like moving down the road, but it could also be pumping that blood out faster than we can even put it in. So there are some potential downsides to that CPR.
That's good. So you talked about you had a abbreviation DDD, detect, direct, and devices. What was that? Is that just for hemorrhage control that we're looking at?
Yes. Yeah, really just as a quick guideline for hemorrhage control. And it's not a rule. Honestly, it's just when I'm helping people focus, and I use it for teaching, but I've used it on calls as well, where I've said we got the three things that we're going to do here first. Find it, that detect, direct pressure, get that pressure on, and then we could start working on all the devices. And again, it's not to say that you couldn't put a tourniquet on quickly if you're prepared and you're ready to do so, and it's an extremity hemorrhage and you can see it and it's going to solve the problem, man, do it. But generally, people who are not as practiced with wound packing, with pressure dressings, with tourniquets, wind up spending extra time manipulating the device and focusing. And if there's anything that looks like it's something wrong, it's a natural part of the human brain that we get locked in on troubleshooting, right? You pull the tourniquet out and it doesn't look right, or it's tied down too tight. And how do we open it back up, or anything along those lines? We get focused in on that. And meanwhile, somebody could just go, Okay, I haven't maybe stopped the bleeding completely, but I've slowed it way down. All right, grab me that tourniquet when you're ready, and let's put that as, high and tight on their leg, and then I'll be able to remove my hand and we can move on. But at least I've stopped the bleeding now, and it's not still coming out while we're fiddling with the tourniquet or the pressure dressing or the wound packing or the hemostatic gauze or whatever it happens to be.
Yeah, I appreciate that because 10 or 15 years ago, when we started really pushing the tourniquets and wound packing again, hemostatic gauze was no longer a mysterious toy that only the government had. We kind of got away from direct pressure. A lot of people went straight to the tourniquet, and I see a lot of guys carry the tourniquet on their belt, and I think that's great. When you have one hand left and somebody's bleeding, you've got your tool right there, and you can apply it. That's a great idea. Yeah, we do like our mnemonics in training: detect, direct, and devices. You said something that I really appreciate is that you use that in the classroom, but I'm the education guy. I believe in teaching the way we actually fight. So we train as we fight. So if we're going to go out there and actually do it that way, we're training properly. And that's why we see the transition in education away from the textbook model, the registry model, and the real way when we try to bring those together. I know not everybody's on board with that yet, but we're going to get there. So you got me with the word a little bit before because the last time I spoke, I got to brag about my favorite decompression where I got to double decompress the guy who had, gotten hit by a car into another one, and he was massive chest trauma. So are there times we should? You're saying we don't needle decompress everybody who's in traumatic arrest?
That's correct. Yeah. So that's the direction that we're definitely moving. And again, a big aspect of that is prioritization of resources and the fact that, when we're verbalizing or when someone's writing out an algorithm, and again, here's where I get excited because I agree with you. I want to see the way that we teach is useful to people on the streets. And that's why I love, the McSwain project is we're going, from the streets to the surgical suites. So we're tying all that together. But with the decompression, it was really zooming people in. They were getting appropriately task focused. But then, we gotta find the needle. We're maybe having a hard time, putting the needle in. And why is it over the rib or under the rib? It's a low frequency, high impact skill, and people they get super super focused. So when you see it on an algorithm where we're talking about it on a tabletop, it's and then I would decompress the chest. But in the real world, it can often take more time and more resources than that and be a challenge, like I say, by the roadside and somebody's trying to hold a flashlight so you can see the chest, and we're cutting open the parka, and the feathers are going all over the place. So it can be much more of a challenge. So if we have a good reason to. Now your example I thought was a good one though, because I default to, and what my recommendation is, and again, I don't know what the ultimate recommendations are going to come out addressing this, but if it's significant chest trauma and you go, yeah, there's just a good chance it looks like that, then no one is asking you to do a whole checklist that before you decompress the chest, you need to make sure that there is tracheal deviation and JVD and chest trauma and hyperresonant lung sounds. And I want you to percuss the chest, and you need to check at least 5 to 10 things before you say that. It's just, we don't just go in there and go, oh, it's a traumatic cardiac arrest, needles in both sides. Does that help make it a little bit more realistic?
So, until I get my portable chest X-ray out in the field, I think we've got a fair idea of how to decide if we're going to needle the chest or not. And let's be honest, needle decompression is the least of all good ways to access the pleural cavity. And if we could get chest tubes or fingered thoracostomies, those are much better choices going into the future. And some protocols will allow it, which is pretty cool. So once we're on scene, we've got basic hemorrhage control done. I think that needle decompression can be considered part of airway. What else do we want to do for airway and ventilation? And do we start that with chest compressions, or do we still clear a few things up with the A before we move on to the C? What do you think?
Well, again, I don't want to speak for the guidelines that are going to be coming out because they're still being worked on it, and I have an official that I'm not even supposed to talk too much about the discussions, but I'd say that it's reasonable to look at the airway, because if we're first and make sure that not necessarily it's definitive, but we've got it secured. So we're getting air in and out, because that's really going to also help us decide, do we have a tension pneumothorax situation? And are we going to do needle decompression, or, like you say, some services able to do finger thoracostomy, even, because we're going to need to be able to relieve that again before our CPR efforts are going to do anything. And if we're doing CPR first, it's going to make any of those combined airway respirations issues, interventions, very difficult. So they're saying, like, look, just hold off. It might be reasonable to say, look, hold off on the respirations until we get this stuff in place rapidly, so that we can address that stuff. But again, these are still questions that are a little bit up in the air. So right now, I would look at, let's make sure that we've got, just rapidly secure that airway, and then implementing compressions after that. Again, your mileage may vary. Here's where we can also start looking at some things like additional tools that are rolling out, like point of care ultrasound, that are going to make it much easier for us to be able to make these decisions. So I don't want anybody to hear this and think like, well, okay, he's not really answering the questions because he's saying he'd probably lean towards airway in most situations, but if it looks like CPR will help, how do we differentiate that? That's why we're looking at ways we can answer these important questions, and things like ultrasound, point of care ultrasound, may be able to help us differentiate.
So, Rommie, I have a split life. In New York, I get to practice as a medic. Here in my local town, I'm an overeducated EMT, which is a good spot to be. I really enjoy that. So would it be fair to say that I can still manage a traumatic arrest and use some of these principles, even though I'm not doing needle compression, I don't have IV access? Can I still stick with quality compressions, hemorrhage control, rapid transport? Is that stuff still going to be useful to me, or do we need to sit around and wait for all these toys?
No, I totally agree that, again, getting to, for any of these devices, and a specific recommendation, I'm glad you mentioned it, related to point of care ultrasound, is that it can be a good tool, but like any of these tools, they should not slow down our transport to the surgical suite. And that must go along with all of the things that we can do to facilitate a handoff to our colleagues in the emergency department and the trauma surgeons therein. So what I try to keep in mind with that is, it's not just liberal applications of sirens and gasoline, as some would say, drive as fast as you can, but a good trauma alert, effective transport decision. What hospital are we going to, and what's the best way to get there, by ground or by air, by highway or by back road, whatever it happens to be. So those are significant decisions. And an effective patient handover, which has been referred to as the black hole, the Bermuda Triangle of healthcare overall, is any kind of patient handover. And when it comes to significant trauma patients, and especially traumatic cardiac arrest, an effective patient handover can not only help the patient move forward rapidly and effectively from pre-hospital to in-hospital emergency department and surgery, but a bad handover can not only slow that down, it can have us moving backwards, because assessments that I've done, key life-saving interventions that I've provided, and I can say whether they were successful or unsuccessful, what the results were, that helps us move forward. If I'm not communicating that effectively, then that winds up moving us backwards. So again, you see some of the challenges in making protocols for this, or studying it, or for me, of course, even answering your questions directly, is there are so many things that are tangled up. But again, it comes back to point of care ultrasound or any of these great tools. They're great, but they can't slow us down. And when we're talking about making sure we're not getting slowed down, it's not just a matter of driving fast. It's a matter of really facilitating the patient's movement forward.
Okay. Um, Endotracheal intubation. That's why I became a medic. I get to put the tube in the trachea. Is it a mandatory?
It's not a mandatory. Absolutely, and fantastic question, right? Like if we need to be able to stuff plastic tubes in patients' mouths and noses and ears and whatever else, right? But it's funny that you say that because we joke about it a little bit, but when we go into these low frequency, high pressure events, right? Like medics want to do what medics want to do. And we see it at every level too. The surgeons want to cut, right? Whatever we want to do for our training, we all want to do the best for the patient. So there's this pull that says, I want to do the best thing. And it's the gold standard is endotracheal intubation. But it's not necessarily for traumatic cardiac arrest. Number one, we want that smooth facilitation. And if I can use a supraglottic airway, like an iGel, to do that, these newer iGels, again, for those experienced providers, we used to think of these supraglottic airways as backup, half rescue, secondary, all these lower things. Now, they're not intubation, but man, what you get now from the new King devices, iGel, the new versions of the LMAs are so much better that, man, for that speed, you got a lot of bang for your buck with that. And again, all of this stuff helping us to move forward.
Just got to notice from my clinical job that our BLS providers will be doing iGels now in the field. And it's great because it takes that one step away from the busy medic and it shares it with another perfectly competent clinician who can do that for them. I like that. But what my EMTs can't give is epinephrine. They can't start the IV. So what's the plan here? I get IV access. Do we start with epi? Do we start with fluids? Do we go straight to something that's a colloid? What's the best choice?
Excellent questions, and these are big questions that we've been looking at. So, some of the recommendations, we in EMS, like we want an answer, right? Like we want to know, like just give me the answer. We don't like this subtle back and forth. I don't know. We're not sure. You decide, right? Um, slight leaning towards fluids, like lactated ringers. But that doesn't mean you put normal saline in a patient and they're going to explode. And I'm sorry, what else were you asking?
Well, I mean, we've got. I'm thinking epi with our IV access. Are we going to bother giving epi now? I know still my current protocol is that I do, and I get it. Protocol's not always on cutting edge. But do you see a future where epi's not part of this resuscitation anymore?
Yes, for some resuscitations, absolutely. Again, the utility of epinephrine in these traumatic cardiac arrests is really going to be more as a pressor. And it's going to be a good general use pressor for that. We're sort of using it as a like you would as a push dose pressor effectively. So it may still have a role, just like we're talking about what might the role be for epi in medical cardiac arrest. As we're looking at so many aspects where epi's not going to be the answer. That honestly, I don't even know why people focus on it so much for medical cardiac arrest. We look at these medications, we just go, okay, like any medication, have a reason to give it. Oxygen, have a reason to give it. They're hypoxic, right? If the epi is going to serve a purpose and not just occupy a spot on an algorithm, then go ahead and give it if that's gonna, if it's gonna do something. Again, in traumatic cardiac arrest, possibly pressor, but much lower on the general priority list. It's not being looked at as a life-saving intervention like hemorrhage control is, or if indicated, needle chest decompression or finger thoracostomy, things like that. Much lower down.
I understand that. And I think we're still using epinephrine because 120 years ago they gave it to a couple of dogs and it looked like it worked. And nobody would say, let's do a real RCT on this and find out because I didn't want to be in the control group for that one. It's hard with cardiac arrest to make these decisions. And of course, nobody makes money on epinephrine, so there's nobody advocating for or against right now. So I notice is when I take my traumatic cardiac arrest into the trauma center, we do a proper handover. We let the residents do their thing there. They usually cut the chest open. They do several things. And what I notice is if they don't open the chest up, they usually do some sort of an ultrasound to look at the heart. So what decision are they making? And I think I know the answer because usually right after that, somebody looks at the clock and announces the time of death.
Well, multiple things, right? There's certainly looking at the like a fast exam, which is going to look at internal bleeding. They're going to be able to evaluate again, depending on the operator and the probe and different factors, but they're also going to be able to look at a pericardial tamponade if there's blood surrounding the heart, and that's certainly something that we can do something about. But the combination of factors may wind up being overwhelming for a traumatic cardiac arrest by the time we've gotten them to the patient. And the ultrasound allows them to evaluate so much so rapidly without the risks that come with opening up their chest, that it's really a game changer with that. But the biggest thing with all of that being said is simply that that cardiac standstill, that if we've been providing interventions and maybe the heart is still moving. This is someone who still, I hate to say it as wants to live. That's a phrase that we've used in the past, but you know, who isn't going to want to live? But there's something to work with that we're going to continue. And maybe at that point, this is a patient who we said before, like, look, a pre-hospital decision was made that we're not going to be administering blood products, you know, sort of by the gallon for every traumatic cardiac arrest patient. But for a patient that we've been working that still has that cardiac motion that we can see on the point of care ultrasound, that's somebody who we're going to be, now we're going to be giving them blood. And again, I'm not saying this is a general recommendation, but just as an example to answer that question, that okay, are we calling this because there's just an overwhelming number of factors, and we don't have any evidence that this person has any resources left with which we can work, or is this someone who is still, man, their heart's still beating, they're young, and with some more aggressive resuscitation efforts that we can bring to bear at the hospital, and with surgical efforts to start closing up internal hemorrhage, by God, we're going to do everything we can to give them the fighting chance.
It makes me wonder if we have point of care ultrasound, if that might change our decision a little bit with the persistent PEA cardiac arrest, where maybe we're seeing something that's not PEA. It's a heart that's beating and it's going to continue to beat. We just don't have any fluid there, any blood for it to pump. Do you think that might change our decision on field terminations in those cases?
Oh, 100%. Absolutely. It's like looking at a patient and doing a good assessment. And it's absolutely true that with if you're trying to decide if a patient is hypoglycemic, that a good assessment is going to get you in that direction. But also now you could check their blood sugar and we'll have a number. And now it doesn't mean that we're not going to do a good assessment, but the same thing with, you know, point of care ultrasound is now we don't have to sort of guess what's going on and interpret a lot of different factors going on with the patient in our assessment, along with the EKG and the history and the context. All of that is still important, but also we could just look at the heart and see if it's moving.
Cool. I think it's great. So if we do transport, what kind of safety factors are there? I remember I got yelled at when I was a young EMT, probably 18 or 19 years old, and I'm transporting just across town with a cardiac arrest. And my feeling, I was driving, ambulance number 19, and I went, I don't know, 20, 30 miles an hour, lights and sirens on. And I see my paramedic, who's several years my senior. My Connecticut friends will know Fran. Poke her head up from the back and say, "What are you waiting for? Let's get there." And so I hammered it down. So what do you think? Lights and sirens, a little less than lights and sirens. Does it have anything to do with the patient condition or destination?
Oh, absolutely, absolutely. And this is going to probably produce a good amount of EMS hate mail, right? Because again, we're in EMS, right? What do they give us? They give all of us. They give us an ambulance. What does that ambulance always have? Man, that thing's got lights and sirens. Some of the coolest blinkies that we've got anywhere around, right? And rumblers and thumpers and every other kind of thing to make noise. But what we know, And this isn't a guess. This isn't as complicated as the bundles of care and the difficult numbers and sorting everything out that we were talking about in the beginning of this presentation, man. We know the minute you turn lights and sirens on, the data says over and over again in all parts of rural and urban and different parts of the country that it greatly increases the chance that we're going to get into a collision. But let's set that aside. Let's just talk about real world in the back of the ambulance, right? Anybody who's been in the back of an ambulance and has said up front, I need you to move it and I need you to get going now. And there may be times when that's appropriate, but we know what happens to us in the back of that ambulance. Life-saving interventions, it's all we can do to hang on to the monkey bars or belt ourselves in and not just either we get thrown around or everything else gets thrown around and mashes into us, right? And what are we saying about this traumatic cardiac arrest? Certainly, yes, efficient. And that's why I was careful to use that word efficient transport to the hospital and making sure that the hospital has a good notification they're ready. And we have it clear in our heads after we've done our life-saving interventions. We're still assessing our patient. Man, we are going to give that. We are going to be the rock star of patient handovers. That's what's going to really facilitate it. It makes it tough to justify taking someone from one car crash and going, well, holy heck, let's drive like a bat out of hell and possibly risk getting in another car collision, a car accident. We had two major motor vehicle collisions involving ambulances just in the past 3 days. And it's happening over and over again. I know that, you get the notifications, I get the notifications. It's going to take EMS a while, I think, to come to terms with that. It's not always the best way to go. We want to be able to. So what criteria, Ram? Answer the question. Life-saving interventions are completed, right? We've able to do the things that are going to save a life, because driving like crazy isn't going to save a life. Getting those life-saving interventions in early while the patient still has some fight, if you want to look at it that way, that's what's going to help them. So a smooth ride may be able to facilitate that. A trauma center that's relatively close. So the lights and sirens going to make those minutes of difference for real now, for real? Answer you have to ask yourself that question in your heart of hearts. Is it really going to make that difference that it's going to be worth us possibly getting into another collision on the way to that hospital? Because we know it just raises those numbers. So in some situations, sure, but life-saving interventions always complete, and really make sure that you're asking yourself that question in your heart of hearts.
I think it was 2 years ago in the winter, my EMT partner turned me in from a ground medic into a flight medic, and it was for just that purpose. I sailed towards the door. So I was watching this new show, The Pit. I don't know if anybody's seen it. It's on HBO Max. It's pretty good. I mean, as TV dramas go, they've got a lot of the medicine right. I noticed they were using a Roboa to stop bleeding below the umbilicus. There were thoracotomies. There was, I think somebody talked about ECMO, TXA as a medication, which we just approved here in Connecticut. What do you think? Do we keep going with these things?
It's a challenge because for pre-hospital management of traumatic cardiac arrest, Roboa, certainly they've had success with it in London. Extremely large, urban, high volume, high resource center. But it's not really a routine recommendation for EMS providers. There's got to be a rapid system an established system for rapid surgical intervention. And really that the indication is clear, just like we were saying before, man, this is a high resource, low frequency, high intensity, life-saving intervention. Like we were talking about with the needle chest decompression, this isn't just, gosh, they're bleeding a lot. If you don't mind, I'll take a half step back for people who don't know what Roboa is. Roboa is resuscitative endovascular. So in resuscitation, endovascular in the vascular system, balloon occlusion of the aorta, which is exactly what it sounds like. They put a balloon in, usually in the leg. They snake it up in through to the aorta, And if someone's bleeding out and we just can't compress that internal hemorrhage all over the place, and by God, they're going to die if we leave them like this, but they're going to live if we could sort of almost put a tourniquet around their whole lower body. Then they inflate that balloon in the aorta and they keep blood perfusion from, again, it depends on exactly how they do it and where they do it, but like you think of it like from the belly button up, there's still circulation, but they've shut off circulation from everything down below. So if the pelvic fracture and femoral bleeding and all of that kind of stuff is a wreck, Reboa might be an intervention that could shut off all of that long enough for blood resuscitation, blood product resuscitation, and surgical intervention to sew that up, or at least to get the patient to that. So it's possible. But it's a highly complex system, and it's not for everybody. For ECMO, or extracorporeal membrane oxygenation, heart-lung machine, it's not really supported for traumatic cardiac arrest. There's a very small number that may benefit from it, but since we're talking about it as a general thing, it's not going to be any magic solution for traumatic cardiac arrest. This tends to be more helpful for medical cardiac arrest patients where, wow, we've figured out the thing or things that put them into that put them into medical cardiac arrest, but it's going to take a while for us to sort that out. In the meantime, if we can keep them going and keep the circulation with ECMO, with the heart-lung machine, it's going to give us the time to solve their problem, and then we can remove them from the heart-lung machine, restart their heart, and they're gonna get up and going. So those are the big the Reboa and the ECMO. They're exciting and they're cool, and they can help a certain select number of patients, but they're highly complex. They're very resource intensive. They're not for everybody. This isn't just for any traumatic cardiac arrest that you might be able to get to the hospital. But the Pit is a cool show.
It's a great show. I'm going to finish up the last episode tomorrow. It's a holiday for us. So I got 109 people on the screen, and these are ALS providers, BLS providers. Mary, you can probably tell us later how many states are represented, but I know just the people I know from at least 4 or 5 different states. Not everybody has pre-hospital blood. Few have POCUS, ultrasound out in the field. There's a lot of us who don't have all these choices. Of all the choices that you've offered me today, which one would you like all of us to attempt first?
Oh, point of care ultrasound. I think it's the way of the future. It's got so many different uses, from helping you find an IV to all of the things that we talked about and more. But when it comes to implementation of point of care ultrasound, of course, it's not only the cost has come down to be reasonable for some services, but it's about the system, not just the units. When you're looking at the cost, is this something where we're going to have a supervisor or a critical care medic or a small number of units and a few paramedics who are highly trained in being able to use the point of care ultrasound in more than one way? Because it's not, well, we get point of care ultrasound and we get to use it right away for 10 different things. The unit may be able to do 10 different things, but it takes training and practice and regular updates so that you know what you're looking at rapidly when you're able to use the unit. Or are we going to say, we're going to have a unit like this on every truck, and we're going to have to train and perform quality assurance and quality improvement for every single paramedic? So that's going to be the challenge. With all that being said, it's a lot to keep in mind. But point of care ultrasound is going to offer the most utility. And again, I really think the most bang for your buck for traumatic cardiac arrest and way beyond.
I get the impression, because I don't use ultrasound where I work, I feel like the ultrasound of the 2020s will be the capnography of the 20-teens. We got it for one thing, and then we found out it does 5 other things. Do you agree with me?
Oh, 100%. Absolutely. I'm really excited. We don't have it where I practice right now. I'm hoping that we're going to be able to get it sometime in the near future. And man, I'm really excited to start practicing and sort of dig my teeth into it. But not literally. Don't actually bite the units or the patients. That is not a
No,
recommendation.
no, and people in your state office are real sticklers for that. So, I want to put this down because I'm going to use it in my next class. What was the mnemonic for quick bleeding control on traumatic arrests?
Uh, so detect, because sometimes people are afraid to, they've got blood soaking through and they're like, whatever you do, don't remove the dressings, don't remove the anything. Look, if it's still bleeding through, let's make sure that our direct pressure and our interventions are going where it needs to be. So detect, direct pressure. It's the fastest thing, man. Just get it on there, not just on the surface, mashing down where the blood is coming out. But if there's a blood vessel in there and we need to stick a thumb or a finger in there, direct pressure, compress it against the bone. It needs to be pressure against something, not just mushing on some meat. Devices, the whole host of them. And there really is that fourth one beyond for the ALS providers is don't dilute. Again, I said before, there's a role in making sure that the heart has fluid to pump around, but we're not just automatically going, okay, stop the bleed. Two of the biggest, toilet paper tubes we can stick in somebody's arms, and all the fluid we got, squeeze the bags.
And that was all the fun. Man, Rommie, it's been awesome talking to you about this. Can we look at some of the questions people put in the chat? Because we're at 10 o'clock Eastern, so we're all ready for bed. I think our West Coast people are getting ready for dinner. I see a whole bunch of them up here, and can I just run them off to you real quick and see what you think and give me the best forward answer you can?
Yeah, that's fantastic. Absolutely. This is about you guys, not about us.
Excellent. So I want to read off what's up there. And if anybody wants to contribute another question, we'll take them in the chat. And then once we're done, if you want to say hi to us verbally, you're welcome to. So I saw one that was important. Neil Keitlinger asked us about complete heart block and how I think the answer to that is a complete heart block is usually a very slow heart rate. Could that lead to a car accident or a fall or something that causes traumatic cardiac arrest?
Oh my gosh. You talk about trying hard not to do the war stories, right? I was coming back from a fire training at the Connecticut Fire Academy and watched a car accident occur on Interstate 84 on the side of the road. And there was no other cars with blinky lights around. And I'm in my personal vehicle, pulled over and started, and the long and short of it was started working a traumatic cardiac arrest on the side of 84. But there were no skid marks or any attempt to stop or steer as the patient went through. So as I was trying to hand over to the for real paramedics who were coming in with the ambulance, I want to let them know I think that this was a medical cardiac arrest that transitioned to traumatic injuries. So they didn't get distracted immediately by the trauma. So I agree. That's certainly something that we need to assess early on and decide as best we can.
Good. Neil, I appreciate that
Medical
question because it reminds us that sometimes these calls, we have to do a little detective work. We already answered what the CN Marsh was. It's circulation. And let's see here, fluid replacement. Sorry, somebody typed and moved my screen. Fluid replacement. Yeah, we did talk about choosing something. Honestly, ringers versus saline, up to your system. We used to say that for trauma, it was ringers, but if your system doesn't have it, no big deal. They both come out to be pasta water in the vasculature, right? It's salty water. If you had your choice of fluids, what would it be for cardiac arrest? Traumatic
ringers.
cardiac.
Yeah, ringers, honestly, ringers first, and blood if it looked like this was something that we could really save. If we'd gotten far enough to say like, oh yeah, this is something we need to pour absolutely everything into. Something, forgive me, someone, the efforts.
Someone, yeah. And I saw somebody brought up plasma light. I think there's hetastarch out there. There's options for people who choose not to have blood. So we've got options that are out there that may be an acceptable substitute. Let's see here. There's some comments about pulling PHTLS, TECC, TCCC, and teach them. I think that combining these are probably a good idea. What do you think, Robbie? Combining efforts and getting away from completely separate theories,
Oh,
bring some of these trains
absolutely.
together.
Absolutely. And it's funny that you say that because that's a big part of where these different services, the different organizations are going. And it's a big part of, sorry, it's over on the screen over here. I promise I'm pointing at it. The recent joint statement and this multi-year guidelines project. It's not necessarily that, hey, we're going to have all the answers, but one of the first things we want to do is say, let's pull everything in together because multiple guidelines all over the place are effectively no guidelines. They're unusable guidelines. And our people are trying to save lives. And if we're looking at the new data and we're saying, okay, it's not a fraction of 1%, but it may be as high as almost 10%, that's a lot of lives our people could be saving if we give them the good guidelines, consistent guidelines to make good, consistent decision making.
That's great. Matt Houston asks about here in Connecticut, we direct our providers to provide 8 minutes or 4 cycles of quality manual CPR before using a CPR device like a Lucas. And, that's going to be up to each individual med control or statewide policies. So I don't see an immediate change to that, but it might be something to think about in a little bit. Let's see here. I think that most med controls that are going to see POCUS in the field will be very comfortable with adding that piece of information. That came from Rob Schreiber. And I know right here in the New Haven region, they were testing out some POCUS devices, and how we actually implement that will be a good thing. We'll see what actually happens soon. So 39 states, we really appreciate that.